Good afternoon, everybody, and welcome to our webinar today, Assessing the Rural Heart Program. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. I am coming to you from Anawan land, from Armidale. We have three presenters for you today, which is fantastic. We have Dr. Jenny May. Sorry, I'm just finding my information here. Jenny May is a GP from Tamworth. She's a very experienced GP with an active clinical practice. As part of her role as Director of the University of Newcastle Department of Rural Health. Someone's just got some noise coming through. Just put yourself on mute.
It's like the beginning of a mini holiday.
So there we go. Don't you just love technology? When it's all working, it's wonderful. Sorry about that. Let me start from the beginning. We have Professor Jenny May here today. She's an experienced GP with an active clinical practice. As part of her role as Director of the University of Newcastle Department of Rural Health, she oversees the Rural Health Multidisciplinary Training Program for students in the Northwest, Tablelands and North Coast. Jenny is a regular contributor on ABC's The Drum, presenting on local and national health workforce issues. We also have Donna Block. She's a primary care improvement officer and sits in the Tamworth office. And we have Peter Mullen, who is a digital health officer and has a regional role right across the patch, I believe, for the PHN. All right, well, Jenny's going to speak first, so I'll before we do go any further, I'm having a terrible day today. Don't forget to type in your questions in the question box, and Donna's going to facilitate those today. So, and there'll be an evaluation that will pop up at the end, so please fill it in. I think that's it. Thanks, Jenny.
Jenny, we can't hear you.
Still can't hear you. Let me just go here. Try now.
Thank you. I could see that I was muted by the organisers and I was going, whoops. So thank you, everybody, and I share the acknowledgement of country, and I'm here on Gamilaroi country. I'm just going to talk to you as a fallible sharing GP about a way to approach the heart health check and some observations I've recently made, which I found really helpful. So I'm hoping you can see my slides. Can I get a thumbs up from Donna that you can see the slide? So can I be heard? Yep.
I think we've lost your sound again. Oops.
Can you hear?
Try now.
What about that?
Yes, I can hear you now. Yes.
Okay, so and Donna, I'll get you just to give me the thumbs down because I can see you on my screen if we lose it again. So clearly we hear about the 699 and the 177. So the 699 is the heart health assessment item, which we can charge once a year, but interestingly cannot be claimed in conjunction with other health assessment items, 701 to 715 for VRGPs. So that was an interesting thing that I didn't know before. So really you can do a heart health assessment on anybody who is over the age of 30 years, and obviously for whom that there is some suspicion or some relativity as to why you might want to do that more fulsome screening. And the screening and the item number comprises the collection of relevant information, including taking a history, taking a basic physical examination, including blood pressure, cholesterol, and I think blood sugar should be part of that, initiating interventions and referrals as indicated, implementing a management plan, and providing the patient with preventative health care and advice and information. So this is how I go about it, but there are multiple ways to skin this cat. Am I back, Donna? Yeah, okay. So I'm having trouble advancing the slides. That's my problem, because if I hit the enter bar, I mute myself. So I might just continue with the next slide. And my only wondering is whether, Jenny, you can take control of the presentation in terms of moving the slides. So the important thing here is to plan ahead. So what you need to do is to order the bloods prior to the consultation that you decide in which you're going to do a heart health check. There are some key things that you should do, and they are second nature to most of us. They are electrolytes, liver function tests, HbA1c, a random BSL, a fasting lipid profile, and a total cholesterol is not enough. We need an LDL, we need a triglyceride, and we actually need an HDL ratio if we can get it. And we also need urine microalbumin. And this is a really important addition to the tests that we previously thought of a heart health check. Now, also at the consult, before you start going through the heart health check, which I'm going to hopefully show you on best practice, it is important to get the patient's blood pressure, their weight, their height, and their BMI, and their pulse and waist circumference, and write them on a piece of paper. Sometimes some of these values do not insert easily into the documents that you're working on. So if you've got them jotted down on a piece of paper, you'll save yourself a lot of trouble unless you can run two screens, which some people can, running best practice and another part. Now, I'm going to try and, advance this presentation, and I'm going to try the page down, page up key, or anything that I can try to see if I can advance it, which I'm not able to do. There we are, done it. Okay, so that's what we just said. Write down the key lab results as they do not auto-load. Okay, so the next thing to do is to jump onto that, into best practice, into that CVD Risk Calculator, which we all know about, and pop in your numbers if you know them in advance of starting the heart health check. Why do I say that? Because that's the sort of information that you're going to want in the heart health check. And as I said, if you've done it prior, you'll save yourself a lot of time and agony. So here we are. Let's go in and find within that add the templates, the heart health check, CVD risk assessment form, which is the first top of the red arrow, and the second one, the My Healthy Heart Plan. And you're going to want to add those, you can see in the bottom right, add those to your list of templates that you have on your screen ready to roll. So let's go into the heart health check CVD risk form first, and it offers to put in medications, so yes please. It also offers to put in a whole lot of those height and weight BMI things that we were talking about before, that we were hoping were in your system and calculated prior to inserting. So really good move. I've got mine set for recording values in the last year, and I think that's probably a pretty reasonable way to go, but obviously you can do that and you can customize that to suit yourself. So here we are. We'll go down all this tick box exercise of what will be inserted into our CVD risk plan. Some of the questions are really interesting. The smoking one, yes, we can work that out, and we can work out packs per year. I love the one, describe your diet. And I did this on a patient, and I wrote in their responses. My patient said, it's great. What does that mean? So obviously you need to discern what great means. And if great means Kentucky Fried 5 days a week, or Kentucky or means an understanding of the food pyramid. Also important is, I guess, talking to your patient and having that meaningful discussion, which we'll talk a little bit more about as we go along, about their alcohol intake. And you can see that with that drop-down menu, that's giving you quite a reasonable range of options of ways in which you can enunciate that. Now, if you look further down, you can see that they ask at this point for some of those lab results that you've copied down or printed out prior to commencing the heart health check. And again, they will be inserted, but you actually have to put them into this document. So it's tedious, I know, but if you can do that bit of pre-planning, it works. So let's see if I can move on to the next slide, because we've been doing fabulously getting this far. Yeah, okay. So here we are. Here is my CVD risk calculator, and here's where all those numbers hopefully will magically appear. And as I said, you will not see a lot of new information on this. This is the information that you're inserting. But I've put up there, really importantly, that you can be CVD high risk if you have diabetes and you're over the age of 60.
Sorry, Jen, we've lost your audio. Hi, everyone. I'm just going to be the audio for Jenny May, as she has lost hers. So after doing the cardiovascular risk assessment, this is the take-home plan that you give to your patients. Working through the plan marries the current with the aspiration. The plan is given to the patient and can be a reference point, increasing their understanding of cardiac risk. The tailored advice is consistent with risk and your knowledge of the patient. Aspiration on left, goals on the right. If overweight, consider portion size, salt restriction, and have a goal weight. Set realistic alcohol goals, non-alcohol free days and limits. Other tailored advice around stress or monitoring, and i.e. gestational diabetes. And tailor your local options. Often you know what activities are available that are not Heart Foundation related, easy fit or gentle exercise or other. Practice nurses, allied health colleagues have a great knowledge about community-based programs. So I think that's, I'm so sorry that we've had technical difficulties today. The IT gods are not smiling upon us. And Jenny May, thank you so much for putting together your presentation. And we will hopefully be able to offer you a copy of the slides as well as a recording of the webinar. All right, Donna, we might hand over to you if you'd like to unmute yourself.
Which I have done. So please let me know that you can hear me, Jen.
Yes, I can. Now I'm just going to share your screen.
Okay, can you see my front page of my presentation?
Not yet. Yes, I can.
Lovely, thank you. Now let's see how we go this time. We'll just pray that it's not a Tamworth problem. So welcome everyone. I'm coming to you today from Kamilaroi country as well too, along with Jenny. We're in the same township. So just jumping straight in now. So what do we know? We've had health assessments for a long time, and the 699 has been around for 2+ years too as well. But the uptake's been quite slow and obviously being impacted by pandemic and face-to-face opportunities. But it's not just been that, it's also been about the money. You know, is it going to be financially viable for us to invest our time in these two as well? I actually think the answer to that question is yes. And here's a few reasons why. The opportunity used to just be limited to the 45 to 74-year-olds. It's now opened up to those that are from the age of 30 up. We've not had that opportunity to work preventatively and through the MBS before. So that's a great new selling point for us as a practice. Short and sharp and to the point, 20 minutes in total. It's easy to clinic, it's easy to repeat that. And patients currently are very interested in their health. We can all think of a few celebrities that we know that have passed away from this impact. So it's very much front of mind at the moment. So it's opportunistic for us to be focusing in this way. So what you've got in front of you is just a bit of a roadmap. Think about in terms of what reminders you're putting in your systems. Where could you make sure that you actually capture all those significant health assessment opportunities, not leaving out any of the other ones that are greater time-based, and therefore you can invest more time with your patient. And consider your 699 as that one that you would do for those in-between years. You know, you've got your diabetes risk assessments, you've got 3 opportunities for that in that 10-year period, plus a 45 to 49-year-old health assessment. You would never do a 699 instead of one of those if it was relevant. You would use it other than in those opportunities. So, if you want to, and think in terms of when you're engaging with your patient about, they do this type of annualised care themselves already when they go and see the dentist. They all know they need to see the dentist regularly. It's not something new. They focus that way. We want to encourage them to think about this as health hygiene that they do on a regular basis too. So where would we start with that? So what we've got here is an average practice. Now I took a look at our PHN data based 1st of September, so it's as current as I can make it. And as you can see, the average practice has got about 4,000 patients. Think in terms of 1 GP for a SWIBI of 1,000 patients. So assuming that, we might have 4 GPs in this average practice. Approximately half of those patients are actually already in the right age demographic, but as we can see from the done figure, that we actually aren't looking at the 699 in a way that's making much inroads at this present point in time. What is also interesting at that point in time is we have around 1/3 of our patients already have the measures in place to be able to calculate that CVD risk. So in broad terms, this is actually the QI measure number 8. When you look at your dashboard report that your PCI brings along to you, and it actually focuses on the 45 to 74-year-old age bracket. Another cohort that's not evidenced here that I'd like you to think about in terms as an opportunity is that we actually have practices, a lot of them, that are doing pre-employment medicals or post-employment medicals for patients. They come to see us very irregularly or maybe only the once, and they don't think of themselves as being part of our practice because they live elsewhere. And unfortunately, we may be doing that also. So, but the reality is for these clients that we see from time to time, we may actually only be the only healthcare they're actually accessing. They think in terms of, oh, I get to see a GP every 3 years. They'll let me know if something's wrong. And unfortunately, maybe nobody is actually looking after those. So what if you could be the difference and you could actually have a conversation that might actually spark them to actually start their own health journey in a more proactive way? So getting back to the active patient cohort, you can use your CAT4 tool that comes with your PenCat software to find the patients that already have this measure in place. And of course, you can broaden that to actually look at your 30 to 74-year-old cohort. The link is here for you to be able to access the page on the website that actually has the recipes for the CVD, and there's multiple recipes there. So you can cherry pick that, work out how you want to focus, what you'd like to do it, but also to have a look at all the other great information that's there for you to access to as well. You might like to do this as your next QI activity. And if you need help with this, you all have a PCIO that's there to support your practice. So please reach out to them. They're only too willing to help you do that. Now, once you've got these patients that you know and you've produced the report, how you're going to go about contacting them is up to you. You use your usual processes via SMS, mail, snail mail, phone, however you're going to do that. But if you need to order further pathology, offer to leave that with them at the pathology company. Most of you guys have something that's local on site or easy to do that. So now if you can get that down there the next day, and while you're on the phone with the patient, actually book them into a clinic in a fortnight's time, happy days. You actually got them going and you haven't even finished the phone call yet, okay? These ones are easy to find because we've already got the information we need already there for us to actually access. What about those we don't know? What else could we try? Oh, by the way, everything that we're discussing today, please take it in terms of it's just an idea and an example. Use it for inspiration. Come up with your own ideas, share them with us. We love new ideas. So it's not meant in any other ways as to try and think of something new. Those patients that are already in our appointment book, already sitting in the waiting room, let's grab their attention. Let's maybe take all the posters down, take everything out of the practice so that when they walk in, they think, oh my God, what's going on here? There's something different. Or maybe just leave up all the heart health information. Let's involve the kids. Let's actually put up some colouring in. Maybe we can actually grab the Heart Foundation's logo and make that a colouring in competition for the kids and put it up everywhere. Patients love seeing kids' artwork, and it can be the conversation starter in your practice. Use your digital displays to actually run heart health information. Involve the whole practice team when you're doing this. Have the reception actually working on this area too as well. The reception team are such a valuable part of our practice and they have so much to offer in terms of engagement with this. With all of this too as well. Now, how could we do that? The reception, if we involve them, what we can actually do is actually use those guys to actually maybe do a little bit of surveying in the waiting room while the patients are waiting to see the clinicians. Let's let no opportunity slide past us. If you think in terms of that valuable waiting time while they wait to see a clinician, we can use that. It's actually a nice little resource for us. And just a few examples that I have here, what you could use to survey the patients while they're waiting. I love the Osiris tool. It's one of my favourite tools to use. It captures so much information about our patients and we can get those thinking juices going. It's quite powerful when they score themselves. It is recommended to do every 2 years. It's also in your clinical software, but you can print these up and they can actually start thinking about this stuff before they see you, okay? If you don't want to waste the ink, if you think in terms of something else I've got to print up, then there I put the ways to contact the marketing people so that you can actually just have the brochure sent out to you. They come in a box of about 500, so you don't have to worry about using up your ink. So once the patient's completed this, they take them into their consult. The reception don't take them back. It's actually meant to be something that they take with them. And this can be the trigger to initiate the conversation. The GP can decide which health assessment's appropriate, get the pathology ordered if that needs to be, but before the patient leaves that day, make sure we book them in for that health assessment. Another screening tool that you could use the same way is the family history, the RACGP family history screening questionnaire. The RACGP guidelines book actually has lots of lovely screening tools in it. There's a great kidney one as well too. There's a couple others there. Have a look through. Use them. They're fantastic. This one's focused very much on chronic disease in the family history, in the family actually. And of course, if you're just waiting until your patient's actually in front of the clinician to fire some questions at them, you're going to get it. No, everybody's fine. This is giving them that time to actually think about it before they see you. And a third example, if you like, is the PHN Social and Lifestyle History Questionnaire. This actually captures 6 different pieces of information about the patient and finishes with some biometric measures. Now, if they're happy to do that while they're waiting, you could set up a little station in the waiting room, or they can pop into a treatment room, or they can just leave it till they see one of the clinicians and you can capture it then. Don't get hung up on who's actually capturing this information. This is just meant to be a conversation starter. If you get any information out of this, of course, you're going to record it in the clinical software. No biggie, okay? That's just what you would normally do anyway. The important thing is to make sure that you have your next, your appointment book set up and ready to go with a health assessment clinic in there, ready to go for when these patients come out from seeing the GP or the nurse. Okay, typical example of a clinic. You all guys all know how to do this. I'm not trying to teach you how to suck eggs, but just a couple of points here. I've created this with an appointment type of a heart health assessment with the item number there, so that if our clinicians, I think, what's that jolly item number? Well, guess what? It's already here for them. They don't have to think about it. So that makes life easier for them. And the other thing is too, that we actually get to see 12 patients on the day. So this is a nice little neat 2-hour session with the nurse and with the doctor. So it's easily to actually accomplish that. And what does it get to achieve us? Well, we see the 12 patients and we actually end up with an hourly rate for this 2-hour session around $460 for the hour, $9.20 for the 2 hours. Not bad. Not bad. What else could we use that to do? So if that's one session, what will happen if we change it up a bit? So one session looks like this. It's just for one nurse, one doctor. If you've got more clinicians you want to try it with, scale it up. It's easy to do. We're not actually trying anything that's revolutionary here. We might like to do it for the pit porter. We might like to make this our QI activity. What are we going to achieve if we do that? Well, we'll get the 12 questions done, 140 odd patients. We still haven't taken a lot of our clinicians' time up to actually accomplish that, but it's a great little nice little QI activity. Great, we're really happy with that. We're excited, we're on board. Let's go for broke. Let's try for 12 months. What are we going to achieve in 12 months? We're just replicating and duplicating what we've already done. So I've given you a week off for Christmas here. I'm being a realist here. We're going to see around the 600 patients. We're going to use about 100 hours of our GP or our nurse. And we're going to generate a significant amount of income. Now, maybe you've been thinking about bringing on a new nurse, wondering how you're going to afford to do that, wondering if it's going to be worth your while. I would suggest this is a great way to look at as a way to be actually able to do that, to actually then you'll have so much more time that you haven't actually had to take up with anything else, and you can actually then use the nurse how you want for everything else. Remember when you do this, that if you want to, you can mix it up any way you like. You know, it's totally up to you. If you do want to mix it up and you want to make sure that you capture those other significant health assessment opportunities, the 40 to 49-year-old ones, the 45 to 49-year-old ones, your First Nations people who have those annualised health assessments, what else could this look like? Okay, I've built a similar clinic, kept to the 2-hour session so that if you need to, you can just replicate again. We've got a smaller number of health assessments. We've chucked in a different time-based health assessments, still stuck with 2 hours a day. And if we wanted to mix it up, we could possibly achieve something that's a little bit more generous in the hourly rate. Totally up to you how you do this and how you want to replicate it. Once you've got your patient there, you're actually able to do this, remember discussing with the patient that you'd like to make this an annualised opportunity. Now, if you do this, it's just like that annual dentist appointment. You know, we're not being revolutionary in how we're thinking about that. And if you get the agreement, make sure you set the reminder again for next year. And maybe you could even offer that when they come next year, you'll make sure you'll capture their flu shot at the same time. You'll save them another visit, you know, but what we actually maximise is the patient engagement, which equals a patient for life and also means better health outcomes. So that's it. That's my small little contribution to today. I've popped some references in there, and if you've got any questions, then please reach out and let us know. Thank you.
Thanks so much, Donna. I'll hand over to you, Pete.
Thanks, Jen. Can you see my screen there with a BP patient file?
No, we can see you're connected to GoToWebinar screen.
Okay.
Oh, hold on a sec. It's because I'm not sharing you, am I? Let me just have a look. Oh, did you do that yourself?
No. There we
Sorry,
go. Now I can show my screen. Okay, now can we see a BP screen?
Not yet. I can't.
I can, Pete.
You can? Okay, excellent. Alrighty, so I'm just going to quickly run through a sent referral. Normally I do this in about 45 minutes. Today we're going to get through it in a couple of minutes, so bear with me. Launching it out of BP here, it's the same, exactly the same for using Medical Directory, just launch it out of your sidebar. You can see it launches into the patient view. These tabs here, obviously you've got your patient view and your practice view for the practice managers that are in. This is a really good tool for you to be able to see any park referrals across the practice and things like that. You need to be in a patient to see that, but you just need to, you can use your dummy patient. So we've got our park referrals, our Hunter New England LHD referrals, and our non-LHD referrals. So they're referrals that go through so that the PHN commissioned service providers and private specialists and the like. But we'll jump straight in and create a referral. Now, I apologise for going quickly with this. You can see it pulls through all the patient information. I'm going to do today using a dummy database. So unfortunately, I've only got very limited options with data. And the only one we have in there is actually a University of Newcastle study that some practices are using. But I'll go through and show how that works. Now, as we sent referral, always, we're searching by specialty or condition. So with the example I'm going to use today, it's a dietetics and nutrition specialty. I could just as easily type in cardiac rehabilitation or other adult nutritional and dietetic concern and come up with the same result. We've got to flow down through the algorithm, so you can't jump ahead. So you've got to either go select urgent or non-urgent. Then it's a private referral. And again, if you are working in the live database, you'll have public and private options. This is just, I've got limited options in my test database. So we'll select the local area for Tamworth. I'm actually sitting down in Warramine Lands at the moment, down at beautiful Port Stephens. And then you can see we've got the University of Newcastle Rural Heart Study. So that study is actually a referral through a dietitian. It's a telehealth study, and they're looking at healthy rural hearts. You can see that information comes up in that pop-up box that only appears before you select. So it's a little tip there for young players. That's a really good way to see if there's any limitations on the service or information about who you're referring to. We drop down through the form. We're just selecting out allied health services. We're referring to a dietitian. We're referring for cardiac, and you can see each time I tick this, these red stars are turned into green stars. Just in the interest of time, we won't type the referral letter, but that's exactly like what you type in the first paragraph, your templated referral letters. Dear doctor, thank you for seeing this patient, and flow it through with all that examination history, provisional diagnosis and management to date. If there's any relevant investigations, you can attach those quite easily. You're just ticking the box. That's put an HbA1c into that thing. But normally, again, I've got a dummy patient, so there'd be a lot more. You probably have more relevant investigations, but it's a matter of just ticking those, and they will go on there. Any allergies and adverse reactions, you can see that will pull through directly from the patient file over here. It asks you for your relevant medical history. If there's anything relevant, again, you just tick the whatever might be relevant to that particular referral. Again, using a dummy patient, you'll have current meds or past prescriptions there, just a matter of ticking those. With any of these, if you want to tick the lot, you can just tick the box. Otherwise, you can just tick them as that flows through. You can add in progress notes, but just again, simply by ticking the box. Today's notes won't go in because they won't have been written to the actual patient file until you close the patient file. That's the way the best practices database works. So until it's written to the database, Sent can't see it. You can see all the patient information flows through direct from your patient file. That information you can't change in here. It's got a gold padlock next to it. You've got to update it in your patient file and then just refresh the content button down below, and then that will actually go through. Any insurance information, DVA, Medicare, all that pulls through automatically from your patient file, as does your information as the referrer. Now, I should have mentioned, if you're a nurse doing these, nurses can now do these referrals. You won't be able to submit at the bottom, but you will be able to park it. So we'll cover that in a second as well. Now, for attaching things in the clinical software, just a matter of clicking the attach from software. That will then have a look in your correspondence in, or and I'm using, I apologise, I'm using BP terms here, but that's what I'm more familiar with at the moment. But you can see here that we've got the healthy heart check and the two forms that Jenny mentioned when she did her presentation. So we can attach both of those and just update the attachments, and you can see that's adding those forms on there quite quickly. We've got a missing field. I've obviously missed something. I just click here, it'll take me up there, takes me to the relevant part of the form. Patient's not in an aged care facility, and now we can go forward and park that referral. Ask me, do I really want to park it? Yes, we do. So if you're a nurse doing that referral, you can then park it. A doctor can come along and review that file simply by being in that patient file. Open the sent referrals. We go to the park referrals, and you can see there's the referral that I've done today. Highlight that. We can resume that referral. Pulls all the information out, pre-populates it, everything as it was, and it's ready to submit. I submit that referral now, bearing in mind I am working in a test database. Please don't submit test referrals into the live system. It gives us a preview of the referral, renders it pretty much as a PDF, and we can actually then submit that referral. You see it goes through, it tells you it's submitting the referral's been sent. Now with a private referral, you don't get that confirmation message that you do get from the LHD. But you can be assured that they do go through. This is again a test database, but this is what our private providers see when they come through, and you can see that referrals drop into their inbox there straight away. So it's almost instantaneous that those referrals go through. They are monitored both by the system and in a live sense, so you can rest assured, even though you may not have got anything through, a confirmation back through, that they have actually gone through. Might just throw up very quickly, and we can jump to questions if we like. That's just contact details for Donna and myself, and also the BPAC help desk. If you're having any sent issues, that help desk number there might be useful, and also you can email e-referrals at thphn.com.au. So those contact details are there. But more than happy also, if you've got questions on sent, give me a call at any time.
Thanks so much, Pete. And we have gone a little bit over time, but I'm sure that's okay. Donna, we did have a question there for you. Can you bill any other item numbers on the same day as a 699?
Well, I would defer back to the clinician here, but I'm sure Jenny's going to say that if it's clinically appropriate, of course. Jen, what do you think? No, looks like, can you hear us, Jen?
Well, we're certainly having trouble with our audio today, which isn't good. I have unmuted everybody, all of the attendees. If anyone would like to ask a question, you can just unmute yourself by clicking on the microphone. Or type a question in. And don't forget that we will have a recording of this webinar up on our website. It should be up there by Monday with a copy of the slides. Thanks everybody for coming, and don't forget to fill in the evaluation that will pop up at the end. Thank you.
Thanks everyone.
Jenny May has said that she will take questions offline if anybody wants to ask any. So please just send me an email. I know you've all got my email, and I can forward them on to her. Thank you. Bye.
Bye.